best for the world. This webinar held by the Saudi German Hospital Group from different cities, from Cairo, Riyadh, Jeddah, and also Dubai and Dammam. Today we have Dr. Helmut Steinmetz. He is a chairman chairman and professor of neurology at Goethe University Hospital in Frankfurt, and he is one of the most famous. Actually, he has more than 30 years experience in the neurology. And also, I will come to my colleague from Dr. Shireen from Cairo, Prof. Mahmoud Sabri from Riyadh, and Dr. Aisha, consultant in neurosurgery from Dammam, and Dr. Yusri also from Dubai. Welcome all, and we pass the mic to Prof. Helmut to enjoy us with this beautiful lecture. Thank you.
Yes, thank you very much, Dr. Majid. I hope all of you can see and hear me now. Best Sunday greetings from Frankfurt, Germany to all of you. It has always been a pleasure meeting many of you in the audience, hopefully, but this year it was difficult for reasons you all know. So I hope we will meet again in the future. And in the meantime, it's a pleasure for me to give this talk I was invited to give about acute ischemic stroke, mismatch is brain. So I was told that the audience is probably quite heterogeneous. So of course, specialist neurologists among you, but also non-neurologists and also nurses. So I will try to make myself understandable for all of you and not use too many high-end neurology abbreviations that nobody understands. And to start with, acute stroke, as you all know, is a matter of time. Time is brain is something everybody knows. I mean, this is almost common knowledge for everybody. So, of course, I didn't entitle my talk as time is brain, but mismatch is brain. I will go into that. As all of you know, the treatment of ischemic stroke has been revolutionized in the last 20 years. The first thing was thrombolysis. I will go into that. The second thing just 5 years ago was mechanical thrombectomy. I will also go into that. But of course, before we can do that, the patient has to arrive early in the hospital, which is relatively easy in Germany. Not always, but relatively easy in Germany. Sometimes it's more difficult in other countries with denser population and worse transportation systems. So of course the patient has to be early in the hospital, but then once he's there, our work starts and we have to be fast. Door to needle times should be short, and a stroke team should be present, knowing what to do, and treat the patient right, and then transfer him to a stroke unit. So having a team knowing to deal with the condition stroke is of utmost importance. It saves, so the number needed to treat, I will go into that. And just having a stroke team and a stroke unit is 10. I will not go into that, but start now with my talk. Mismatch is brain. What do I need? What do I mean by that? One moment. I have to. What? Okay. So, mismatch is the following. This is a famous illustration from Jean-Claude Baron from France. This is 20 years old, this illustration based on his research work 30 to 20 years ago. So what you see here in red is if the patient arrives with a neurological deficit in the hospital, he's likely to have a small ischemic core, an established infarct already, which we will not be able to resolve. The patient also will have an outer zone, oligemia named here, where the tissue is functioning well and where no infarct will develop because collateralization is sufficient. The zone in between, the light blue zone here between dark blue and red, this is what Baron and previous researchers named penumbra, and which we today, in a little bit more easy to understand language, name tissue at risk, or tissue at risk is a pathophysiological term, difficult to measure. I will mainly talk about how to measure that tissue at risk, and for that, the term is mismatch, as I will show you. It's mainly an imaging term, mismatch, but important to know all these three terms mean the same: penumbra, tissue at risk, and mismatch. It's the target of recanalization therapy, this zone. To mismatch is simply the difference between the infarct at admission and the infarct at discharge if you are unable to treat the patient effectively. That's what I mean by mismatch. That something like this exists, that penumbra, tissue at risk mismatch exists, is evidenced by this meta-analytic data about the effectiveness of intravenous thrombolysis in the 4.5-hour window. What you see here on this axis is the odds of continuing to live independently and alive, of course, with TPA compared to not having received TPA. So the odds are the higher, the more early you receive the TPA. You see here, that's an abbreviation which I will mention many times in my talk, NNT, meaning number needed to treat. So statistically, it's you have to treat 4 patients in order to leave 1 alive and living independently instead of being dead or living dependently, needing help for all daily activities. So number needed to treat 4 in the first 90 minutes. That's the golden hour of TPA treatment. Very effective treatment. However, of course, as all of you know, not many people arrive at the hospital or receive TPA within this golden hour. But if they do, they're quite well off. So the odds of benefiting from the treatment then go down by time. Time is brain, of course. And the traditional or conventional and legal limit of applying TPA, as you all know, is 4.5 hours. But my talk will be about what comes then, because time is brain is simple, that's everybody knows that, but what happens here in this time window beyond 4.5 hours with TPA? That's mismatch is brain. I will go into that. So you can draw the same curve for the mechanical thrombectomy patients. In Germany, let me mention that. In Germany, 20 to 25% of the ischemic stroke patients now receive TPA treatment, and maybe 5 to 10% of them receive, in addition, mechanical thrombectomy if they have large vessel occlusion, which has not opened up due to TPA within 30 minutes or so. So you can draw the same curve. That's, again, the odds of being better with mechanical thrombectomy compared to without TPA alone. And you can see time is brain, of course. Here, the 6 to 7 hour time window closes, but still, as with the TPA patients that I showed you, the question is, what happens then in the red circle? So you have the lower limit of the 95% confidence interval passes the baseline at 7.3 hours. That's the end of statistically significant treatment, effective treatment. But of course, in this large, widespread confidence interval, you can assume that there are many individual patients who will benefit from treatment. What kind of research has been done on this time window beyond 7 hours of brain ischemia? I will go into a short history of several interesting findings before I come to the more recent clinical studies. So one example of what happens to the brain in middle cerebral artery occlusion, that's mostly the model for that, beyond 7 hours, has been established by Jean-Claude Baron, the one where I showed you the illustration as the first, in the second slide of my talk. They did in the 90s, 30 years ago, they did studies in France and Caen in the Normandy, in apes and baboons, where they applied permanent middle cerebral artery occlusion and then looked what happened using oxygen positron emission tomography. So historical studies shown here, and these studies, this is one baboon shown here, and they looked what happens up to 24 hours, and that's shown in the next slide. They showed that the metabolic rate of oxygen goes down from 1 hour to 7 to 24 hours after application of the occlusion. So there's continuing deterioration of the tissue until 24 hours and maybe even longer, but that's where they stopped measuring. Cerebral blood flow deteriorates 1, 7, 24 hours. So there's continuous deterioration until 24 hours. And the oxygen extraction fraction, OEF, similarly continues to deteriorate until 24 hours. So based on these data, there's at least some possibility that tissue damage continues to develop over 24 hours and not over 4.5 or 7 or 6 hours. And if this is so, maybe the window for treatment is much longer than what we currently think and do. So next kind of evidence from 15 years ago, German study. This is patients having received TPA, thrombolysis, and they looked using transcranial Doppler ultrasonography. They looked who of them recanalized in the next 24 hours. And what you see here, that's the clinical score, let's say, so the clinical improvement. What you see here is that those recanalizing within 30 minutes had clinical improvement. Those recanalizing within 30 minutes and 6 hours had improvement, but also those who recanalized between 6 and 24 hours. Only those who did not recanalize at all did not show any benefit of the TPA clinically and angiologically by recanalization. So this is human data compared to the last data who were animal data. This is human data suggesting that there may be a window of opportunity for recanalization treatment up to 24 hours and not only 4 or 6. So, and the last evidence, this is certainly the strongest, comes from the more recent magnetic resonance studies of infarct development. Here in this case, the DIFFUSE study, diffusion weighted imaging. They looked for the development of the established infarct, the infarct core, from baseline 0.0 up to 12 hours. And what you see here, that there are, and each line is an individual. You see that this red line is an individual, a so-called fast grower. So the infarct core almost explodes from time point 0 to time point 4 hours, from 0 to 180 milliliters in volume. So this is a bad case, I would say, a fast grower. But there are other cases, as you see here. The green one, same sample, same condition, permanent MCA occlusion, which did not recanalize up to 12 hours. This is a slow grower. So even at the time point 11 hours, the patient still has no infarct growth. And of course, you can imagine that this is a case who has tremendous potential of benefiting from treatment, even in the 7+ hour window, whereas the other one certainly does not. And this is exactly what I'm talking about. Mismatch is brain. This is infarct core. Now, how to measure the mismatch? The concept is intellectually appealing, but how to measure it? And this is what the following studies that I will show you have been doing in various different ways. The first is the diffuse 3 study, published 2 years ago in the New England Journal. It's the follow-up to the diffuse 2 that I showed you, the diffuse 2 that I showed you in the last slide. They did the following. So you have to read that with me. So they followed patients with an occlusion of the intracranial internal carotid artery and or main stem M1 segment of the middle cerebral artery, proven by CTA or MRA. The time window, and that was the new thing about this study, is that the time window for randomizing the patient was 6 to 16 hours. I mean, the 6-hour studies, the big 5 of mechanical thrombectomy, had already been done and published, so you couldn't randomize patients in the 6-hour time window, but of course you could randomize 6 to 16-hour patients, and they defined the penumbra or tissue at risk or mismatch using magnetic resonance, DWI, or CT perfusion with a certain software, the rapid software. The initial infarct core had to be relatively small. The penumbra had to be at least 15 milliliters, and the ratio between penumbra and infarct core had to be 1.8, meaning that the penumbra had to be 80% or more larger than the already established infarct core according to imaging. And what did they find? So they randomized the patient in best medical treatment versus best medical treatment plus mechanical thrombectomy. And I'll show you the results in a moment. So this is how the images look. Many of you will have similar images in their hospitals, I hope. This is the infarct core in this single case, 23 milliliters at randomization. This is the penumbra tissue at risk. And the difference between both is the mismatch. And the mismatch ratio here is 5.6. So the penumbra is 5 times larger than the established infarct core. Patient was randomized into either mechanical thrombectomy or best medical treatment alone. And that's what they find. Of 92 patients having been randomized to endovascular treatment, 41 were independent at 90 days, compared to 15 of 90 patients who were randomized to medical therapy alone. So this is a number needed to treat, sensational of 3. That's as good as the golden hour TPA treatment within the 6 to 16 hour window for these middle cerebral artery occlusion patients. So the next study, and this is even more interesting for many of you because you don't need that highly equipped imaging technology and software as the people doing the diffuse 3 study. It's the DAWN study. They also they also used a mismatch, but a different one. I will come into that now. Once again, the inclusion criteria, because that's difficult, that's always important to know. Occlusion, same entry criterion as in the diffuse study. Intracranial, internal carotid, or main stem of the middle cerebral artery, occluded according to CTA or MRA. The patient had to be in the 6 to 24-hour time window. So this is even longer than the 16-hour window in the diffuse study. He had to be more or less healthy before randomization and stroke. And the mismatch in this case was defined by a little bit more simple as in the diffuse study, because you didn't really need that highly equipped technology, radiological technology, because they defined as an inclusion criterion the clinical imaging mismatch, meaning that you only had to image the infarct core, for instance, by DWI. So if your infarct core DWI lesion was of that size and the patient was severely neurologically affected, you had a mismatch, so a clinical imaging mismatch. If it was this size, or if I will not go into details, but the main thing is that you had to have a small infarct core, for example, defined by DWI or by CT perfusion, in combination with a big deficit. And that was the mismatch, the CIM. This is a very attractive definition of mismatch. And at least as attractive was the result of the study. So that's what they did. Infarct core, as you see here, small infarct core, big clinical deficit, patient was randomized, and they had the same result as in the diffuse 3 study for a longer time window, up to 24 hours, and a more easy concept of mismatch definition. They had 52 of 107 thrombectomy patients alive and independent, compared to only 13 of 99 in the control group, NNT of 3. So that's 2 ways of defining mismatch beyond the 4.5 to 6 hour window for recanalization treatment. Let me now come to this. In the subgroup analysis of the DAWN trial, they stratified between those patients who were randomized 6 to 12 hours after onset of their stroke, and those with onset between 12 and 24 hours after onset of their stroke. And the amazing thing is that they did not find a difference in the effectivity and the effectiveness of mechanical thrombectomy. So all of these 12 to 24 hours patients were slow growers, as you have seen in one of the past slides, slow growers whose benefit was as good, as high as in the 6 to 12 hour time window. So that's really a new opportunity for stroke treatment, even up to 24 hours. For, I agree, a relatively small number of patients, of course. It's not that every second stroke patient will qualify for that treatment. So is this also true, or do these results also apply for the real-time world in which you and I live? Here's the answer. That's a stroke paper, which you can just read in the current issue of Stroke. That's from China, and they did observational studies with, so you see the number up here, 12,000 participants, checking whether in real life, in China's real life, the results are as good as in the well-defined, high-end US international multi-center stroke context. And the simple answer is yes, it's as effective. For patients with aspects larger than 5, I'll not go into that, mechanical thrombectomy showed significant superiority over TPA alone, as it was associated with a higher percentage of low neurological invalidity and a lower mortality rate, supporting the current guidelines regarding mechanical thrombectomy beyond the 6 hour time window. So this was all about mechanical thrombectomy. Now, is there anything new regarding TPA beyond the 4.5 hour time window? And the answer is yes, it's the EXTEND study. I'll go into that. So the question here is, can we identify individuals, stroke patients, who will benefit from TPA treatment beyond the 4.5 hour time window? That's a long-going discussion. There had been studies 10, 20 years ago addressing this question. Most of them were negative, but this was before the time of valid mismatch imaging. And again, that's the point which makes the difference here in extending the time window for TPA. So the EXTEND inclusion criteria was ischemic stroke of a large range of severity, age beyond 18, no discussion about that, symptom onset 4.5 to 9 hours. So that's that's double as long as the conventional TPA time window. Remarkably, that has to be kept in mind, 2/3 of these extend patients were wake-up patients, where the onset of symptom onset was arbitrarily defined as the midpoint of sleep. So that's something that could be debated, but keep that in mind. Maybe it's a point of discussion. And they did an imaging mismatch, same as in the DIFFUSE-3 study. So no clinical imaging mismatch as at dawn, but an purely imaging-based mismatch for patients with these NIHSS scores using MRI or CT perfusion imaging plus rapid software. The mismatch definition was a little bit different than in the DIFFUSE-3 study. So the infarct core volume had to be below 70. The penumbra only 10 milliliter more than the core volume, and the mismatch ratio had to be almost 20% more penumbra than core. So, so small mismatches were also qualified also for randomization in the EXTEND trial. Then the patients receiving TPA plus medical treatment or medical treatment, conventional medical treatment alone. What's the result of that? You see it here. Number needed to treat of 14 for coming out alive and independent at day 19. Not as effective as the golden hour TPA with an NT of 4 or the 6 or the 0 to 24 hour mechanical thrombectomy for those qualifying for it, but still good. NNT 14 is as good as for TPA in the 4.5 window overall. So quite good for so defined and so identified EXTEND patients receiving TPA without large vessel occlusions, of course. They don't have vessel occlusions because otherwise they would have qualified for mechanical thrombectomy. So what's the message from these 3 studies? The main message is that mechanical recanalization is an option up to 24 hours, that TPA, thrombolysis, is an option up to 9 hours, including patients with unknown time of symptom onset. And as a prerequisite, you have to somehow use a mismatch definition, be it purely imaging-based or be it clinical plus imaging-based. That's what I mentioned down here. Varying definitions of mismatch for those with less highly developed radiological infrastructure. The clinical imaging mismatch is probably the most interesting to go for. Now, as a short repetition, for those who are interested in that, the methods, it's an overview. I already mentioned that, but I'll give you a short overview about the methods of defining the ischemic core. Remember that also non-contrast CT and CCT is a measure, an estimate, very rough, but it's an estimate of the ischemic core, because if you have a normal non-contrast CT, or you have an aspect score of, let's say, 8 or 9, you probably have a small infarct core. And you can use that even for, I would say even for extended time window decisions. This is something many of you will have difficulties with, but we do it right now in patients with normal non-contrast CT plus a presumed ischemic deficit of relevant severity. We do thrombolysis and mechanical thrombectomy depending on what they need, even without measuring infarct cores and penumbras. So probably with non-contrast CT, you probably underestimate the final infarct size. If you have CT perfusion, you can use this criterion, so relative cerebral blood flow, relative regional cerebral blood flow less than 30% is a rough estimate of the infarct core. It's not validated very well, but it has worked in the studies I showed you. And the probably best thing to estimate the established infarct core is the DWI image. But remember, or keep in mind, that you still overestimate the size of the final infarct, at least in cases that you are then able to recanalize successfully, because the initial DWI lesion is a little bit larger than the final infarct size in successfully treated patients. So those are the possible ways of measuring infarct cores. And what do you need for the mismatch? Of course, you need the tissue at risk. And this is the possible definitions of the tissue at risk. So this is what Dawn did, the clinical imaging mismatch. So you just look at the NIHS score. And if the patient has an aspect of 9 and an NIHSS of 20, you have a clinical imaging mismatch. And you can treat him or her with TPA or mechanical thrombectomy, whatever he needs or she. Problem, of course, is validity. I agree. This is not validated, but it has worked in the Dawn study. And that's the argument to do it. Of course, you can also use MR perfusion techniques to measure the penumbra, and CT perfusion techniques. The criterion for that is the Tmax. You measure the CM, the contrast media enhancement curve, and the time to reach the maximum of the contrast arriving in the tissue serves as an estimate of the blood flow and of the penumbra of the tissue at risk, and the deficit compared to the infarct core is then the mismatch. So that about the definitions of core and penumbra in combination mismatch. Now, what about the fourth kind of mismatch I wanted to talk about? I have now 31 minutes, so I'll maybe need another 5 to 8 or maybe 10 minutes. I would like to talk about this kind of mismatch. It's the fourth kind of mismatch established by the recent studies, also two years ago, published in the New England Journal, the Wake Up trial, a big German trial, where it was checked whether the DWI flare mismatch may be able to guide successful TPA treatment in patients who wake up with their neurological deficit or cannot tell you when the deficit started because they have an aphasia. So the time of unknown onset stroke patients, which are about 20% of all. So it's quite a common thing. Every fifth stroke patient cannot tell you or does not know when the symptoms started. So traditionally they were excluded from treatment because you didn't dare to risk bleeding. But what did this study? You can nowadays do an extend-like procedure. You can put the patient in a mismatch imaging protocol like the extend study that did with rapid software. You can do that. But this, as mentioned, we can do that, but not everybody can do that. It depends on your logistics, on your radiologists, on your software, and on the money that you have to pay for the software. It's quite expensive, things like that. So a more easy thing is what I will show you now. It's the DWI flare mismatch. Now, what did the Wake Up trial do? They included patients of all kinds of, with many, with low grade to high end severe strokes, wide age range, unknown symptom onset, as already mentioned, and they required a DWI flare mismatch. I will show you what this is. This is a case up here. this case up here, has a DWI flare mismatch. So you have a patient with a stroke syndrome. He has a DWI lesion of this size, but the almost simultaneously acquired flare picture does not show anything. And from that, you can conclude that this DWI lesion is an infarct in evolution, of course, but this is that the whole thing is not older than 4.5 hours, because the flare lesion takes 4.5 hours to develop. This is another case, subcortical stroke, DWI positive lesion, subcortically, patient with a hemiparesis. There, the flare picture not showing anything. So in these two cases, you can be almost sure that symptom onset is less than 4.5 hours ago. Those patients were excluded from TPA in previous times, but in the Wake Up trial, they were randomized. And I'll show you the results in a minute. Those are the opposite cases. You see a DWI lesion and an already established flare lesion. You can tell here, lesion is older than 4.5. Based on the legal aspects, you would not be allowed to give this patient TPA unless you put him in the extend protocol and image the perfusion core mismatch, which you could do in such a case. And it's likely, I would say, that the patient will have a mismatch between perfusion and diffusion lesion, and then would receive TPA. But here in the Wake Up protocol, it's a no mismatch case, not randomized, same as this one. So what comes out if patients like the ones up here are randomized to TPA or not TPA? That's what you see here. Number needed to treat of 11. Those receiving TPA with a DWI flare mismatch come out better than those receiving conventional, meaning no TPA treatment. So that's the fourth kind of mismatch. The difference here with the DWI flare mismatch is that it's not a tissue at risk penumbra-like mismatch. In this case, the clock is substituted by the DWI flare mismatch. So it's not a penumbral imaging mismatch. It's a substitution by the flare picture in the presence of a DWI lesion. So what are the take-home messages of my talk before we can go into the discussion at 37 minutes of my talk? First, mismatch should guide treatment decisions beyond the 4.5-hour window for TPA or the 6-hour window for mechanical thrombectomy. And of course, time remains brain, that's no doubt. I mean, the faster you are, the better for the patient, but it's not the only factor. It's the fast grower and the slow grower. And the second kind of clock is imaging, using the various mismatch definitions I have given you. So given that, of course, we have no reason to relax, say, okay, we have 24 hours time to go, we can be slow. That's of course not the case. The patient is better off the faster you act. But all treatments and all treatments are most effective in the first hour. Also mechanical thrombectomy, of course. But it's not the only thing, time. There are other ways, mismatch, as mentioned. We have one particular attractive thing for many of you, I think, the clinical deficit to ischemic core mismatch, as used in the DAWN study, as a guide for recanalization therapy beyond the traditional windows. You have perfusion, diffusion, MR imaging as one way of defining a mismatch. You have CT perfusion, penumbra core, as I showed you, Tmax and RCBF below 30%. And you have as the fourth kind of image, the fourth kind of mismatch, the DWI flare mismatch, showing you that the flare negative cases are younger than 4.5 hours if they are unable to tell you that. That's the end of my talk, Mismatch's Brain. I hope it was of interest for you, and I hope we will be able to meet in the future again, hopefully in 21. Well, not very optimistic so far, but we'll see. Maybe in the second half of 21, I'll be looking forward to see many of you, hopefully. And until then, thank you very much for listening to me, and have a good time. Bye-bye.
Thank you, Dr. Helmut, for this wonderful and beautiful information. If you don't mind, I have a question for you, if you don't mind.
Yes, of course. Please.
Yeah, my question is, do you think there is a difference between the posterior circulation penumbra and the anterior circulation penumbra? That the posterior circulation has more penumbra, more time? Last week, I thrombolized a patient with came 41 years, has a heart failure, and he has basilar artery thrombosis in the tip of the basilar, came within 8 hours. So I give him TBA, and also I give him mechanical, I did the mechanical thrombectomy, and next day he becomes conscious, oriented,
yes.
moving. In the other scenario, I did the same thing with him, with another patient, and next day he died. What is your experience regarding posterior circulation? A lot of study doesn't show that like evidence of as the anterior circulation.
Well, very good question. The posterior circulation was excluded from all of these studies that I showed you, as you know. So we don't have any scientific answer to your question. My personal impression, but of course, as you mentioned, we act the same in the posterior circulation, thinking that the effectiveness of treatment is the same, and that's my impression. I would not say that TPA or thrombectomy is even more effective in the posterior circulation than in the anterior one. But my feeling is that it's more or less the same, but I don't have precise data about that. So we do in the posterior, we do the same as in the anterior, but for the posterior, we don't have data. We just have experience, and that's as good as for the anterior circulation.
Thank you, Dr. Helmut. From my colleague, Dr. Shireen, do you have any comment or question to Prof. Helmut?
Thank you, Dr. Helmut, for your informative lecture. Can I ask a question, please?
Yes, of course.
Can we depend on DWI and flare mismatch not only in wake-up strokes, but also in well-known times? Sometimes we have a patient who have passed 6 hours and still have diffusion and flare mismatch. Can we depend on it?
Yes, I would say yes.
Yes, I do so.
So yeah, because that's the substitute of the clock.
Yes, okay.
It's a tissue clock, let's say. Let's put it like that.
Thank you, Dr. Shireen. Prof. Muhammad Sabri, do you have any comment or question for Prof. Helmut?
First of all, thank you very much, Dr. Helmut, and as usual, very mentally full and very organized. You answer our question. Once the question come to my mind, I found the answer in your presentation. So thank you very much.
Thank you.
And actually, what I have come out from this, that dealing with such cases, I cannot say like one-to-one, or it's not like take the guideline and go like a machine. It needs dynamic thinking in every step you do. And when you have the patient at the ER, you have certain criteria and certain plan. Then you go to the image. Your plan could change dramatically. Okay. Mm-hmm. Then you have another advanced imaging. Then it's very diverse. Mm-hmm. So it needs really, and that's what we see in the last years. The advancement in this area is very going on. So my another question, what's more we expect in the coming, for example, 6 months or 1 year, if you have any idea about where we go more? And really, my dream is to have non-invasive, like ultrasound issue, like magnetic issue, rather than going through the catheter for 2 reasons. It's invasive and injurious, although it's done now very safely, and for the price. It's very high price, and this pricing could limit it somehow.
Well, regarding recanalization, well, maybe several answers. So one, as you mentioned, and as mentioned before, we have we are much more into individualized and personalized treatment with these imaging techniques. For instance, if you have a 3-hour patient with a basilar artery syndrome and you do a DWI and the whole brainstem is white, I personally would not start treating him, even though he's in the 4.5-hour window. You know, the fast grower and the slow grower, those individualized concepts are certainly something that we have to get better on. That's one answer. Regarding recanalization, it's difficult to imagine further major steps, except for that you get the patient more faster to the treatment. That's probably that's very simple. I mean, so get the patient faster to the treatment. One concept is in Germany, 2 large cities have stroke mobiles. So not the patient rushes to the hospital, but the other way around. The stroke mobile rushes to a suspected stroke patient and starts treating him in the mobile on his way to the hospital. But of course, that's probably difficult in Cairo, isn't it?
Yeah.
Because as far as people tell me, the streets are jammed almost all the time. So getting the patient faster to the treatment is of course one thing. And the third thing that everybody's hoping for is that we will after so many disappointments, will finally end up having a cytoprotective agent which can prevent the tissue from dying, maybe after recanalization. But so far that's something we are dreaming of.
Yes. Thank you. I leave the floor. Actually, I have many questions, but I leave the floor. I see other questions on the screen. So thank you very much.
Thank you, Dr. Mahmoud. Dr. Aisha from Saudi German, Dammam, do you have any comment or?
Actually, I really loved your session just because tomorrow we're having our stroke simulation drill. It will be the first drill. We had a huge setback during the corona, but now we are on the road. We're opening our stroke center very, very soon. My question to you, do you have experience with the rapid AI? Because we are installing that in our hospital. I am not a neurologist, I'm a neurosurgeon who does a neurointervention. So what is your take on rapid AI? And we chose the modality to be CT, just one go, CT, CTA, and CT perfusion. Do you prefer CT over MRI or the otherwise?
We, of course, we use the rapid software for CT and MRI, as in the studies in the trials that I showed you, and we're quite satisfied with it. But it's probably not as easy for many as it is for us to buy it and to apply it and to have people work with it. So we are very satisfied with it and we use it.
Okay.
And what was the second question? Sorry.
The second question, do you prefer
MRI
CT-based studies or MRI?
Yes. Me personally, I prefer MRI because it's the much more tissue-oriented pathophysiological image. But in clinical practice, in the routine, I would say we do 2/3 CT because it's more easily available, faster, and everybody knows it, know to deal with it even during night times. And yeah.
Did you get cases where you were not satisfied with the CT and you said, okay, let's repeat the thing on MRI, or you're just happy with the CT?
No, I'm certainly, there are more cases where I think the CT has not identified the infarct core correctly than I would say for the MRI. So certainly there's a problem with infarct core identification and penumbra identification with CTP, which is, and the problem is bigger than for the MRI method. That's my feeling.
I see. Okay. My other question is, how do you see the impact of TPA extension on real practice? Because, you know, here, and unfortunately, we're still struggling with the primitive basics to get people give TPA in the window. So what is your experience now? The TPA window is extended. What do you think? Is this good, or is this, you know, like bad?
Yes, I mean, the extend study is one thing and real life is the second thing. And I must confess that as optimistic the extend data are, there are not so many patients fulfilling these criteria. So we do it, but I mean, maybe it's one case a month or so. So it's not that it produces a big new second wave of TPA cases treated, which were not treated in previous times. So it's a relatively rare patient, the extend patient.
Okay, thank you. Thank you very much.
Thank you.
We are looking forward to see you come and visit us in Dammam, and that's a big invitation, a genuine one, because we are starting our stroke unit and we are very enthusiastic. So we could use your experience and helping us launch. So you are welcome in Dammam.
I would love to do that.
Yeah, we're looking forward to see you there.
Thank you, Dr. Aisha. Dr. Prof. Helmut, we have a question from the audience. This question is, shall we consider mechanical thrombectomy the first choice for acute ischemic stroke rather than starting TPA?
Yes, of course. There has been I didn't mention that, the recent Chinese study published in the New England Journal Direct MT, doing mechanical thrombectomy without TPA treatment before mechanical thrombectomy. Of course, you can do that. In our hospital, it's quite rare because most of the patients we see for mechanical thrombectomy are transferals from other hospitals, and they come in with the TPA already dripping. You can do that, although if I would have to decide, and the Chinese study has a number of problems. So, of course, after it has been published, you can do that, directly go for mechanical thrombectomy and leave the TPA, possible, but don't lose too much time. I mean, if you lose 1 hour and the patient has missed the TPA, and after that, it turns out that the thrombus has resolved, he didn't receive an evidence-based, very effective treatment in the meantime. So if you have the opportunity to directly go to the thrombectomy suite, okay, then leave the TPA, no problem with me. But if you have a risk that it takes time, I would start TPA in the meantime. And the Chinese study may not be the final answer to the question, because there are other problems with the study that I will not discuss now.
Thank you, Dr. Prof. Helmut. From my colleague from other city, do you have any question regarding acute ischemic stroke with Professor Helmut?
I just wanted to add, there is one more question from the audience. The question is, what is your experience with Tanic Plus as IV thrombolysis?
Very, very good drug. We don't have it, and it's not approved in Germany. But of course, it's very promising, and the data look great. I'm still asking myself why BI doesn't market that much more strongly, given the nice data they have. But so as far as I know, it cannot be given outside of trials. I mean, we don't have it as a usual drug that we can give to our patients.
Any question, Prof. Mahmoud?
Also, is there any help of neurophysiology, Dr. Helmut, that could add for monitoring the stroke patient in this critical situation?
You mean physiotherapy? Was that the question?
I mean neurophysiology.
Neurophysiology.
Like
I mean,
EEG with
I see. I mean, being a friend of neurophysiology, I really love it. But in case of stroke, it's difficult to. No, I don't see any particular relevance. As
right.
Of course, it's very important in other things, but stroke, I don't see it.
Okay. Of course, also the concept of penumbra, and the only way to assess till now is also through angio, going through the angio suite and the test through the catheterization and the filling. There is any way to test the the collateral, I mean, the collateral.
Okay. Yes, of course. You can eyeball that on the CTA pictures, where you see whether the leptomeningeal filling is good or not. So there's a way of eyeballing by the radiologists how good the collateral situation is or not. And of course, you can. I would say you can use that for clinical decisions also.
Mm-hmm.
Although it's not quantifiable as nicely as with the penumbra volume or things like that.
But I think for the slow grower or rapid growing, what you depend on, and why some person have slow growing of infarction and the other has faster? Is the collateral the only, or
yes, collaterals?
What in your mind other factor?
Time and collaterals.
Right.
Determine fast or slow growth.
Mm-hmm. Thanks very much. Thank you.
Any question from our panelist member?
I think I see some questions on the screen. They can, from the host, can they?
Yeah. There is a question, Prof. Helmut.
Yes.
When the NI we have not to lose, and for you, sir, do you thrombolize or not for NIH score more than 24? Do you thrombolize or not?
Yes.
Hello?
Yes. Unless we see a let's say large demarcated infarction on the CT. If we see that, we wouldn't do it. But just the deficit without a major lesion, we would do TPA and probably look for the large vessels, whether they are occluded. In such a severe syndrome, the patient is very likely to have large vessel occlusion.
Good.
Dr. Steinmetz, I have one last question for you. It's very important.
Yes.
Because we found lately that our hospital was more capable of getting tenecteplase to us, especially during the corona crisis, than TPA.
That's interesting.
Yeah, yeah, yes. You know, and I was a little bit reluctant, honestly, because I don't have the guidelines for it. So honestly, I did not use it.
Yes.
So do you have any recommendation, specific recommendation?
Well, I mean, considering the data that have been published about the tenecteplase, tenecteplase, I would say it's at least as good as TPA, probably better, regarding effectiveness and bleeding complication risk. But on the other hand, I mean, I understand if you are very cautious, but because if something happens and you have applied something that is not even in the guidelines and is maybe not approved in most countries worldwide, you have a legal problem probably. So I must leave that up to you. I probably would decide to give it, but but the cultural situation here is a little bit different because people demand that they are treated, and they make they sue you if you don't treat them aggressively. And in your country, sometimes it's the other way around. They sue you if you have a complication.
You know, actually, when it comes to stroke, I am hoping to create this culture because unfortunately, people would go to hospitals with acute stroke in the window. And they will not get treated. So I am working hard to change the culture in my province where people know they have rights and they need to be treated.
Yes, that's what I think too.
Yeah, thank you. Thank you very much.
And Dr. Aisha, you have to educate people about the ischemic stroke. You have to do something.
Of course, we've done one campaign in the mall, and we will do more.
One question for you, Dr. Helmuth. What is your opinion about the dose of RTPA with the 0.6 in large vessel occlusion function?
There was a study, I think, 5 years ago, finding that that the lower dose is not inferior to the 0.9 dose, and I think it's okay. It's okay to use the lower dose. On the other hand, we do not do it. We use the 0.9 dose because more studies have been done with the 0.9, so there's much more evidence that 0.9 is effective than that the lower dose is non-inferior. And the other thing is that there has been the hypothesis that the lower dosage is, or that the Asian populations are those who benefit more strongly from the lower dose than the European or American populations do. So we stick to the 0.9, but I must agree if you or who else says, I believe in the study that was published and give the lower dose, that's okay. I mean, it's evidence. And your populations are more, let's say, Asian-like than the Central Europeans are.
Any question before we close this wonderful webinar?
Thank you.
Thank you, Dr. Prof. Helmuth, for this wonderful presentation. I hope you have a great night, and thank you for all my colleagues from different cities from Saudi German Hospital. Thank you for Saudi German Hospital to provide this wonderful picture, and good night.
Masalama.
Thank you. Bye-bye.
Masalama. Thank you very much, everybody. Thank you.
Thank you very much. Bye-bye.